Now, another important question. The cardiovascular event was normal LDL. I think in the last few years, we saw a lot of patients in the cath labs, young age, with normal LDL and with atherosclerotic stenosis in their coronaries. What do you think, to relate about those cases? You face something like this?
Yes, actually, definitely. We see many patients with normal LDL and they suffer first or recurrent cardiovascular events. And we, because of this issue, we go back to the residual risk that was discussed a few minutes ago. Because the LDL is not the atherogenic particle in the human body. So the non-HDL has a rule, ApoB has a rule, lipoprotein little a also has a rule, high triglyceridemia has a rule. This is all about the lipid residual risk, rather than other residual risk like thrombotic and inflammatory and all of these things.
Professor Karim Saeed and Professor Shadi. First Professor Karim, then Professor Shadi. What do you think about those patients we sometimes find them in the cath lab with normal LDL and there is a lesions in the coronaries or even any other event in the cardiovascular tree?
Okay. The problem is that we depend upon the LDL cholesterol. We are talking about the LDL cholesterol. But atherosclerosis is not caused by the LDL cholesterol. It's caused by lipoproteins, LDL particles. So we may have a normal cholesterol, but we may have a pathological particles in terms of numbers or in terms of size. Small size tend to be more atherogenic. So we may have to look for advanced lipoprotein analysis. We can go for the ApoB, which is a surrogate for the LDL particle. We can go for the non-HDL, which is parallel to the ApoB. In advanced circumstances, we can go for the MRI spectrometer, which identifies the size and the number of the LDL particles. Also, we can go for the remnants of the VLDL. We can go for the lipoprotein little a. Actually, 50% of the cholesterol in the plaque is derived from not the LDL particles, from the triglyceride-rich particles. On the other hand, we may have other causes for cardiovascular event not related to atherogenesis, type 2 myocardial infarction, vasculitis, and among others.
Mohamed, we will take 30 seconds from your time, please, to let Shadi comment. You want to comment?
Again, I repeat the words of my colleagues. It is not just a number. This is a problem. We are looking for numbers, and it's not just a number. It is patient profile, it is risk category, it is type. As Dr. Karim said, small and dense LDL, we can have two patients having the same LDL level. One is high risk for cardiovascular event and the other is not. The first, which is high risk for cardiovascular event, have a small and dense LDL, which is more atherogenic.
Now I think Dr. Sobeih, he is a lecturer in Zagazig University and he's one of the rising stars also, will give us an answer for this important question, please.
Hello, good evening, dear professors, colleagues, and chairman. And thank you, Professor Ashraf and Professor Saeed Farag, for inviting me to introduce this lecture in that highly educated meeting. So the lecture about cardiovascular events with normal LDL. Much information were said by my colleagues that will make the task easier by regarding the time. So many trials have proved that residual risks still remain after lowering the LDL cholesterol. And well-known Fourier trial after 48 weeks in the arm who took evolocumab, about 42% of patients had LDL lowered to 25 milligram per deciliter or lower. And although that group or that arm had still 12% of the primary endpoints and about 8% of secondary endpoint. So what's the problem? Actually, there's a residual risk that were discussed by my colleague, Dr. Ahmed Darwish, and this is a big issue and very important, but there's another thing which is a molecular level of the LDL particles, as Dr. Karim Saeed said. And looking at the molecular biology and molecule of the lipoproteins, there's a core of mixture and different mixture of the cholesterol ester and the triglycerides. And this is a surface of free cholesterol and phospholipid and covering apolipoprotein, which is responsible for the transportation of the particle inside the bloodstream. LDL mainly is covered by the ApoB, either ApoB 100, which is present in most of the lipoprotein LDL, IDL, VLDL, or ApoB 48, which is covering the chylomicron remnants. Actually, in the routine measurement of the lipid profile, we are measuring the LDL cholesterol concentration, which is very different about the real risk the patient is falling inside. So we are looking at 4 patients who have the same cholesterol concentration, but as we see, they are very different in the composition, in the density, in the heterogeneity, in the molecular biology of the particles of LDL, and that reflects a very different high and low risk profile of these patients, although they are having the same cholesterol concentration. So this measure, which is routinely done, is omitting the LDL real quantity and the quality of the LDL. And as we know, this is the good cholesterol HDL and the bad cholesterol LDL, but actually it's a very heterogeneous group of particles. Not all are having the same hazard. But any particle of the LDL, either better or worse, one ApoB is present on its surface, so it resembles a better, more accurate assessment of the LDL particle. They are differing in the core mixture between the triglycerides and the cholesterol esters, as shown in this diagram. So we have to take the quality and the quantity in a better assessment to reach the real risk profile of the patients. Regarding the quality, the most important is the small dense LDL and oxidized LDL. This is a very important slide. How the small dense lipoprotein LDL is formed. It's formed by the action of the cholesterol ester transfer protein, and this is responsible for the exchange of triglycerides and cholesterol esters between the VLDL, which is a triglyceride-rich particle, and LDL or HDL, which has a few amount of triglycerides. So in increasing the levels of the triglycerides, the shifting of the transfer will be transferring the triglycerides from the VLDL to the LDL or the HDL, so resulting in 2 modified particles. Modified VLDL has less triglycerides and more cholesterol esters, and modified LDL, which has now more triglycerides and less cholesterol esters. That triglyceride excess in the LDL particle got hydrolyzed by the hepatic lipase, so it decreases in size and results in the small, dense LDL. This is, as mentioned by my colleague Darwish, is called the atherogenic triad. High triglycerides, low concentration of LDL and low HDL, and they're very, very, very lethal combination actually, although LDL is very low. What's the risk of the small dense? Small dense LDL has lower affinity for the LDL receptor, so it stays in circulation for big time and stay in contact with the endothelium, and it has this high ability of penetration to subendothelial space and more susceptible to oxidation. The oxidized LDL is very lethal. It causes endothelial dysfunction and releases inflammatory cytokines. As we here see, there is homogeneity in the particles of LDL, so LDL cholesterol is not different from the ApoB measurement, but it makes very difference if there's heterogeneity in the particle composition and the particle size. So it gives overestimation or underestimation of the profile, risk profile of the patient, and not accurate at all. According to the size, there was 3 classes: A, big particles, B, small particles, and intermediate particles in between. Actually, they found that the B subclass was associated with lowest concentration of nitric oxide, which is reflecting the endothelial function. So it was associated with very endothelial dysfunction. And this is the disconcordance when there is normal LDL concentration, but the LDL particle and small dense LDL is very high. We can measure it by the ultracentrifugation, electrophoresis, and the next quality assessment is called electronegative LDL. Normally, the naturally occurring the LDL have positive charge at surface. How it become negative? By certain modification in the surface phospholipid and surface ApoB. ApoB got misfolded and exchanged by another apoproteins and acquired negative charges. What is the hazards of the negative charges? The negative charges makes it more hazardous bind to the endothelium more than the native and higher phospholipolytic activity. And the LDL receptor has negative charges, so there is no there is no attachment to the electronegative LDL, and it goes reversely to 1 minute, please. It goes to the LOX1 receptor, which has the lesion positive, and this is a very hazardous receptor, causing cellular apoptosis and cell death. They found that the LDL negative fraction has the highest release of the cytokines. The last one in the quality is a desialylated LDL, which is removing the sialic acid from the LDL particle. Sialic acid is the terminal carbohydrate in the ApoB, and the transfersialidase enzyme that do the job. So many drugs are now under experiments to target this enzyme, and very hazardous also. The quantity was discussed previously, ApoB and lipoprotein LDLP. LDLP is the most fundamental way to quantify the LDL. More thing is the cumulative exposure also. Cumulative exposure is how much LDL the patient was exposed and how much time he was exposed to. This is all what mentioned.
Okay, I think here the answer also is clearly presented, and I think we have to think about, for those patients with cardiovascular events and normal LDL, we have to think about the ApoB, we have to think about lipoprotein little a, because if we are deceived only by the LDL, I think we will keep the patient, or we will left the patient with risk. Thank you very much, Dr. Sobeih, for your elegant presentation.